as I said, like in the last lecture, truly the initiation of these are to teach myself and to collect some like basic information. And the more you read, the more you know that you don't know. Yeah. So just a quick reminder for us: we have two main types of Doppler. It's the specular, that the one we see displayed by velocity and gradients, and the color Doppler. So the main difference between the pulse and the continuous is continuously sending, continuously receiving. The pulse will send and wait, listen for the upcoming. This is why when this is why in pulse we can specify the site. It's range specific. However, the CW is range ambiguous. So because it's receiving and sending and receiving all the way, so it would give you the highest regardless wherever it is. And this is like just an explanation for what just said. And they will say this is why with pulse wave you can get the stroke volume. However, with CW you cannot, because the stroke volume you need that cross-sectional area and to pulse that place, which you cannot do without the pulse Doppler. And this is an example of the difference between the pulse and the CW. You can see we have an empty box and crisp outlines. We call it what? The modal velocity. And this is the thing that we measured. And from both of them, you can get the VTI, you can get a velocity, you can get a gradient, but each one, it has its own use and benefits. So what's the Nyquist limit? It's the maximum Doppler shift that the machine can record, the probe can record before it starts to have some ambiguity in the range, which we call Aliasing. So it's depend on the sampling rate or pulse repetitive frequency, how much you can sample this one. And the more you can sample, the better understanding of the signal, like coming, going, velocity, and everything. And I brought this example last time. And for the food people, like I will bring this one. I found it's really amazing. See how it's spinning in different direction. If you see this chopper, it's look like it stays still. And whenever he put in the vegetables, it will spin on the opposite side even. It's not just, this is because it's really fast for your eye to detect, like where is the direction of the aliasing. So aliasing, it's when the maximum velocity reached by the Doppler, by the pulse wave Doppler. It's really important. It's not bad. We think that it is like, oh, there is aliasing. Does this mean something negative? No, we use it all the time. We use aliasing all the time in measuring the visa, in knowing there is like stenosis, there is SAM, there is like mid-capillary gradient. It's really important. And I find this video, it's really nice to explain the aliasing. So imagine this is the frame rate sampling for this signal, and then when they drop it, and then they will start to decrease the sampling rate. So this is the same sampling. Then they will start to decrease it. The original is the above. You start to see the change in the waves here. So up to limit, it is acceptable. So when the sampling go less and less, what will happen? You will start to lose the truth. Like you don't know which wave is like in this wave, it's like it's still steady. However, it's really going down. And this one is going down, while in truth, it's going up. So the lower the sampling rate, the false information you get, and this is the aliasing. This is what will happen. So as I told you, we can use it like to calculate, for example, for the visa, regurgitant orifice, regurgitant volume, regurgitant fraction. You can detect if there is stenosis just with Aliasing. You can know that there is significant stenosis, there is significant leak, there is BFO, there is ASD, there is SAM. So always be happy to have this Aliasing. So this is, I'm advertising for this bulb because it looks nice and it's worked very fine. I just have seen it in the internet. So if you look to the light, it's steady, isn't it? Because there is Aliasing. There is always a frame rate, how much this bulb is giving you. In real life, if you take it in slow-mo, the bulb is really glowing like that. But because it's really fast for our eyes, we see it as steady. And whenever it starts like to get used a lot, it will start, you can see it like start to flicker. Yeah. So why and when? Everything, any blood direction, you can pulse it. Any abnormal flow, you can pulse it. Okay? But there are a lot of benefits of pulse wave than, like many people will say, especially like the people who's early in echo, they said if we have ambiguity, why do we, if we have like a limitation, like Aliasing and the limitation in velocity, why don't we use CW all the time and get it on? However, most of the time you want to be specific and you want to measure the sample volume at that site to calculate the volumes and to know the exact disease at that place and to verify if there is any abnormality or not. So in Doppler in general, we need to optimize it. And I'm sorry to say that, but one day I wish our sonographer will present like for us how to optimize. For me, I'm telling you the truth. I'm good at theory, but do not give me the probe and keep me away from it. So I wish like each sonographer will present about one of the things like how to optimize this signal, because it's really important for us to know the right and the wrong, and important for other sonographers and beginner. We will start with like the sample volume when you do the like you never change the sample volume, isn't it? It's set on 4 millimeter, isn't it? So usually it's better to change it from LVOT is different than pulmonary veins, it's different than hepatic. Each one it has its own, so it's better to change it. If it's working, if it's giving you nice waveform, this is the needed thing. But however, if it's not, it's better to go and see what is the best for that. The wall filter, it's important. It's like will eliminate for us in pulse wave. It will eliminate the small velocity that it's not needed, and so you can really clearly see where is the beginning and where is the end of the pulse, and it's not to be too low, so there will be a lot of unnecessary wave and velocities, and it's not to be too high, so we will lose the baseline. Also, the gain, it should be optimized so we can see the crisp model velocity and we can trace it for our VTI. And the sweep, it's depends on the need, but the longer sweep, it's always beneficial, and we will see some example. Even if the patient does not need it, if you take longer beat, you will know more information than nothing. The baseline, it's always important. Sometimes, like we focus, for example, if we want to measure the just in CW, for example, like when we want to measure the mitral regurg, we will focus on the MR signal. However, we will forget about the forward flow. And it's really important to compare, for example, the density of the backward to the forward to see how much. And also in the flow reversal, it's really important. Sometimes you can measure the VTI of the reversal and to see how much it's compared to the antegrade flow. So it will make a difference. Also, the baseline can help you to get rid of the Aliasing, either by increasing your scale or by just shifting the baseline. So the modal velocity is this crisp. It's the one we want whenever there is like increase in the broadening of the signal. This means that it is not an optimal. Either your sample volume is a bit big, or there is like you went deep inside the turbulence, for example, went close to the aortic valve, or the patient may be having too high, for example, cardiac output. So we need to differentiate between that. And the most important is to be aligned as much as possible. Like a lot of the aortic pulse, the aorta is going this way and the pulse is 90 degree, and there is some flickering things that I have pulsed the aortic and get deal with it. So the LVOT is really one of the most important pulse wave signal that we have. So we should pulse it exactly where did we take the LVOT area. However, if we take the annulus, you can go, they said 3 to 5 millimeter below it, just to avoid the flow turbulence. They suggested, 5 to 10 in the guidelines. I have seen 3 to 5 millimeter. You try to make it as crisp as possible, and we'll see how to do it. This is an example of really broad signal that almost like went all the way to the aorta, even if the velocity is not high, but there is too much turbulence. So what if it's a bit high? It will affect the stroke volume, the cardiac output, the cardiac index, the aortic valve area. If you want to calculate QBQS, regurgitant fraction, anything, a lot of things, it will be affected in the process. So how did they propose to do it? They say you will go to the LVOT and in the lower side of the LV side, okay, apical, and go gradually until you reach the aorta. You start to see the broadening, like our first one. You see this one. Then you will go back, push back until you have your crisp and clear signal. This is like in an easy way. I will keep it and with the reference here. So if anyone wants to revise it. So how to know sometimes, is it a good or not? Is it acceptable or not? We should know the normal. Okay, without knowing the normal, you cannot get what is abnormal. So what's the normal velocity for the LVOT? It's the easiest to say 100 plus minus 20. There are multiple numbers proposed. Maximum I have seen is 130. Beyond 130, it is like they say, it is elevated. Okay, so what is elevated? You need to revise it. You need to adjust your place, or it is really, really high. Also, if it is high up to like 1.5, sometimes you cannot use the Bernoulli equation. You need to use the modified Bernoulli, not the simplified that we use. How about the VTI? It's 20 plus minus 2. And people will go from 16 to 23. I have seen some reference. And I'm always saying this story that during my beginning of echo back there is a young lady come with shortness of breath. And she's 27, 28. And they did for her an echo. It was totally normal. She was sent home. After 2 weeks, she came with shortness of breath and she found to have pulmonary edema. So retrospectively, after I saw the investigation, I went back to her previous echo. I saw that the stroke, the VTI and the VTI, LVOT, VTI and velocity were high. So I calculate her cardiac output. It came 10 liters per minute. So she was having hyperthyroidism and high cardiac output failure. Because the signal is high, so why she's complaining from shortness of breath? Shortness of breath because of high cardiac output, not because of low cardiac output. What the thing that we can use? We can use it for, we can know just by the VTI. By the way, VTI per se is a measurement for the heart or cardiac function. Like in ICU, they will have a cut, I think around 12. Whenever the patient is below 12, he is in shock. No need, for example, like the images, sometimes it's difficult. No need to measure the area, no need to measure anything. If you cannot see the views of the heart, if the VTI is as low as 12, this patient is in shock. Okay? And it's really good to know sometimes just the VTI and to monitor the heart and to monitor the things. So we can get the VTI, the stroke volume, the cardiac output, the aortic valve area, the QBQS, the DVI for example, for the mitral valve. And I don't know why I add the aortic valve gradient. So forget. So what do we have here? What's happening? We have two measurements, isn't it? So the first one, what's happened here? What did they include? What is this? This is the valve clip. Any other answers? Huh? So this is commonly to be seen in echo. There is always a wave before the pulse wave of the LVOT, which called the J wave or the pre-systolic wave. They used to calculate, I think, through the cath always. So it's represent the atrial contraction. And if you search the literature, there is a lot of researches about it. Is it absent? What does it indicate? If is it present? What does it indicate? If is it prominent? What does it indicate? And there is really a lot of good talk about it. So what is this one? What we have here? I always tease the juniors resident with this one. Like, how many pulse do we have here? This is the high pulse repetitive frequency. So whenever you have a high velocity, the machine will give you all of these pulses. It still has, it can give you the pulse at that place, but they said still have range ambiguity. But from the shape of the pulse, you can know where is it. Like example, the highest. I don't know if is it useful. Do you think it's useful, or like how much do you depend on that?
Early, right? Yeah, this was created about 15 years ago by one of the vendors, and I think Philip started it first, and then it's called high pulse wave repetition frequency. Then it gives you multiple sample volumes. It could be potentially helpful when you're looking for gradients inside the ventricle, but the problem is actually very ambiguous.
Yeah.
So ambiguous that it's better to do what we call inching or centimetering from the apex all the way down to see where the gradient actually goes. It's like what they call a cheap CW when it first came out.
Okay, good.
No, and to Dr. Chow's point, once you start to see aliasing, then you realize that's where flow starts to accelerate. If you want to measure the velocity, depending on where you are, then you switch to CW, right?
Yeah.
Which is what we do routinely.
Yeah, but it caused, like over the last 15 years, what I noticed is actually caused more problem than it's worth. Because it actually does it automatically unless you switch it off on your machine. And then like you actually accidentally, when you increase your velocity high enough, then it goes into this mode without sometimes noticing. So then it actually causes more problem than it's worth.
And the range ambiguity is is the main problem. You don't know where is the signal coming from. So CW will be the answer. So how about this image? So this image will not give me the stroke volume. It will give me just a stroke. Okay. Always, whenever there is variation, try to average. How much we should average? If you see the guidelines, they will say 5 to 10. Easiest way, average 3 consecutive beats. If you average 3 consecutive beats, you are out of playing, but just do not take one beat. For example, like this one. How about the RBOT pulse? The same, whatever told about the LVOT, it will be said about the RBOT. It's still, you can take it in the short axis or in the long axis. They will say like 5 to 10 millimeter, the same as with the LVOT. and try to get also the modal velocity. Do not go deep into the valve and not away in the LVOT. And it's always good to know the normal values. What are the normal values? It's a bit lower than the LVOT. They will say like 90 plus minus 10 and 15 plus minus 1. This is for the VTI. So what else do we have about the RVOT? If we go back to the LVOT, you will find it is sharp or steep acceleration, because it's from like lower to high, or let's say the aorta has high pressure. Okay, so when the pressure will rise very rapidly and it will be steep, this is the normal. Whenever you have a low cardiac output or low ejection fraction, you'll see this one start to be more rounded and rounded. However, it's the opposite in the RVOT. It should be a bit rounded because it will take time until it's reached the maximum pressure. Whenever we have element of pulmonary hypertension, resistance, PE, like resistance, I mean like pneumonia, advanced lung disease, collapse, whatever, you start to have a steep acceleration time and some deformities on the wave. What do they use to call this one? Long time ago, it's the flying W. Maybe you hear about the flying W. We don't do it anymore. I wish someone do it in one day and give me the image, and I will be proud and happy for that. So what's the proposed acceleration time? Most of the reference will say 120 to 130. This is like the cut for them. Anything between 100 to 130, it's a borderline. You cannot say it's like this patient does not have pulmonary hypertension or have. Anything below 100 up to 80, this is mild to moderate. Anything below 80, this is severe. Anything below 60, either severe, or you think also about pulmonary embolism if you have the 60-60 sign. What else do you see here? The notch, the mid-systolic notch. There will be mid-systolic closure, and this is really one of the good examples I have seen. Oh, by the way, all the images are from here, are from St. Max. This is a really nice one. Like you can tell that there is, like, first of all, very crisp, very nice modal velocity, sharp acceleration, systolic notch, and the image were zoomed and taken in place. Like whoever took it, yeah, took her time, or she took her time, like to do it. So in theory, LVOT should be equal to RVOT in measure of stroke volume. However, the only problem that the LVOT, sometimes we cannot calculate the cross-sectional area very well. I have seen in some of the talks that they will monitor the RV function because just by the VTI. So the VTI over time will start to be reduced and reduced and reduced. Then they will notice that the RV function is start to go down just by the VTI. This is how important. So how about the mitral inflow? I know that all of you are aware about it, but the sample volume, like they will say, it's 1 to 3. So the smaller, the better. It's not unlike the previous. The previous, they will say like 4 to 5, it's okay. So always we don't have a problem. And it's supposed to be at the tips of the mitral valve leaflet. Also, it's not just at the tips. They will say a bit to the lateral wall, okay? Because the flow naturally go to the lateral wall. And the more you have a disease in the mitral valve and the LV, the leaflet, instead of just closing, like opening normally, they would start to open toward the lateral wall. So just do not make it here exactly like at the center. Just try to lean a bit toward the lateral wall. I know you do not pulse it like this image, but just this is an example how much the E wave will be affected just by different position. So it will, if you go like more apical the E wave will be lower. If you go more toward the annulus, the E wave will be also lower. So if the E wave is lower, it will affect our assessment for the valve, it will affect our assessment for the LA pressure, it will affect our assessment for the diastolic dysfunction. A lot of measurements will get involved.
Just go back a little bit. This is actually not correct.
I know.
Because remember, flow actually heads in that direction and around, so it's probably again a bit of an underestimate. But you can tell that because look at this, a little bit of a fuzzy spectral Doppler profile.
It's close to the valve, and you start to have some flow.
Should be in the tips.
Yeah, this is the best image I found like long time ago. Even I don't know where's the source, and I remember looking at it. I said, the perfect is not that perfect also. So also we should measure the pulse wave at the level of the mitral valve annulus. It's really important if we want to calculate the stroke volume through the mitral valve, and if we plan in the future to use the A wave duration for any measurement. And what we can get? A lot, just by pulsing the mitral valve clips. Okay, you can have the E velocity, E over A ratio, E over E prime, deceleration time, acceleration time, respiratory variation, and myocardial performance index. And from the annulus, you can get the A wave duration, the mitral valve VTI, which will give you the stroke volume, the regurgitant volume, regurgitant fraction, and mitral valve area. A lot of calculation can be involved in these things. And this is the difference between when you pulse the mitral valve annulus and the tips sometimes, because usually at the annulus, you will still have continuous flow. You can still have it if the patient is a bit tachycardic, but usually at the normal heart rate, there will be space between the E and A, and it should be low or no flow. Okay, so always be careful when you do the pulse wave and do your measurement. Whenever the waves are funny looking, just have a look at the rhythm. So what do we have here? Normal and fused, normal and fused. So this patient was having 2-to-1 AV block. Yeah. And how about this one? He's in AFib with variation, and this is the L wave. So just do not be. How about this one? All of these are E waves, by the way. 1, 2, 3, 4, 5. So those two E waves are in the same cycle. Those two E waves are in the same cycle. But because this patient has underlying atrial activity, and whenever it will come in different shapes. So this is the A, for example. Then it gives us this wave. Then another A, and it was fused with the E. Then another A, it came exactly at the E. This is why it's so prominent. Then another A, then another. So he's having continuous A waves. And if you give the inflow time to speak, it will tell you something. Those patients, if you see here, for example, let's take this one. So E is more than A. Then E and A are a bit equal. Then E is less than A. Those patients are having some element of diastolic dysfunction just by observing the inflow and its change during respiration. It's exactly as if you're telling the patient to do pulse alpha, and you're decreasing the flow through the mitral valve, and you can see some changes. And those patients, for example, for me, I will pay more attention to their diastolic parameter than, for example, the other patients who have steady and continuous flow. All these are really nice inflows that we're taking here in our lab, and I always keep them as memories. So L wave, I think we have presented many times. It's always confusing, truly, as it's look like, if it's alone, it's look like as an A wave. However, just pay attention to the rhythm and to the overall, the cycles. If there is irregularity, you can see the E prime. You can see the mitral M mode. It will tell you that what is the rhythm. Is it really good or not?
So what's the meaning of L wave? Go back one step.
Okay.
You have to tell us what that means.
Oh.
Can you see an L wave?
Because I did present the inflow before, so
okay. Let's see if they remember. Ashwin? Sorry, I have to call you out. You're the only one here.
It represents elevated pressures, generally a high or a high LA pressure. That's dysfunction, which is a differential.
Yeah. So just to repeat, it means usually elevated left atrial pressure, often it's associated with diastolic dysfunction, and it's also known as the Batman sign. So you have to look at just about here, the 2 ears and then the head. So that's known as the Batman sign. Gotham City.
So usually between the E and the A, there is no or just a little flow. However, when you have a prominent flow with a velocity, like they said, it's exceeding 20 centimeters per second, this will be considered as L wave. And as Dr. Chow said, it will be like signs of elevated LA pressure. It's one of the questions that I was planning to bring. It's what Dr. Chow called this one. It's a Batman. So this question is a gift for everybody. So the numbers, it really varies between the age group. Also, it varies between men and women. What do you need to know? That 120 is almost the cut. Anything above 120 is considered high, and you should look at it. What does it mean, and why it is high, and to consider other, like, for example, if we are doing stress echo, we usually take the inflow. If the inflow is higher than this, like 120, it's good to take also the TDI. Maybe this patient, the shortness of breath that is coming to the lab is because of the diastolic dysfunction, not because of like ischemic or other reference. I will refer you to this article. It's from 2015. It's really nice. If you see there is a lot of information about not just the inflow, also even the mitral, the TDI, the E prime. They include also the E prime for the anterior and the inferior walls in case if you have any diseases in the anterior lateral and septal. It's really amazing. So I was using the computer designer, and then when I wrote TV inflow, tricuspid inflow, it's give me this suggestion. So I took the chance for that. And the tricuspid valve, it's the same idea for the mitral. We will pulse the tips, and you can get the same information. It can be used for a lot of things, but it's mainly we use it for the variation in the inflow. However, there are some people will follow the diastolic dysfunction of the RV. We are struggling with the left side, so how about the right side? But you don't know what will happen in the future. They said you should pulse it. You should pulse it in the guideline. But what's the parameter to use? It's depend on the lab. What do you want to record? Okay, but to pulse the inflow, it's part of the study. What's the velocity? Usually it's lower than the mitral because the annulus of the tricuspid is really wider. So they will say 50 plus minus 20. So it's 30 to 70. This is the acceptable. What we can get, the same information. E over A, E over E prime, deceleration time, respiratory variation, and myocardial performance index. And whoever is interested in right side diastolic dysfunction, I would refer you to this article. You will be amazed about the amount of talk in the right side diastolic dysfunction. So the pulmonary veins, it's good to know for at the beginning the anatomy. Where are the veins? It's not just about the naming. It's how to pulse it the most parallel one. Okay, we should try our best. The first view is mainly for pediatric. It's not for adult, but the rest of the views you can get almost all the veins. You can see, at least you can see the flow. And How about the pulse? All of those are normal. Like the shape will be different from patient to another. However, it should be taken in the right context. So how many waves do we have? We have S1, we have S2. What's the difference between S1 and S2? So this is
No.
no. This is
Yes, but no.
Yes.
yes, but no. Yeah.
Very smart though, Kat.
What's the reason behind the S1 and S2? This is the let me phrase pardon my English. So what's the reason behind S1 and S2? They will say S1.
Would that be fair to say normally we see only one S, but sometimes we do see S1 and S2 separately with a notch? And what is the condition that actually allows you to see that? Or when you see that, what does that mean? When you see S1 and S2 separately? Normally they're one piece, right? Typically.
So S1, they will say that it's the relaxation of the atria before the S2, which is the contraction of the left ventricle and pulling of the mitral. And they say also S2 is not just, I thought initially the S2 is just from the pull of the LV of the mitral annulus and suction effect. They say no, the S2 has a component of the RV contraction. RV contraction when it's pushed the blood from the other side. This is why sometimes you have a lower S compared to D just because of RV dysfunction. Okay, it's good to know these things because it can make sense sometimes when you see it.
Yeah,
so we
add that S1, S2 typically is what we see in a transesophageal echo, much more than transthoracic. So we do see that, and typically we see this in a situation when the when the atrial pressures are very low. So that's the time that actually occurs. Then you can see both our right-sided pressure is low, and typically in patients with TE, we dry them out and also we NPO them. And that's why we could see that on TE more often than transthoracic.
So they said it's fused in 70 to 80% of the patient. However, just before I go to that, this is from our lab. Like, see how many times that we have the S1 and S2, and it's really nice. You can get it. And if you see this one in the middle, they zoom it. She took her time to zoom, to pulse it exactly in the right place. So I say she because most of are girl. And it's really...
and sometimes it's a he.
You mean he or she, right?
Yeah.
Or she or he. Yeah.
What did I say?
She.
She, it.
It's she, him, she, her, they, them. Okay.
So to get it short, they good at it first. They have a good source. The background always affected. So we have 3 antegrade flows and 1 retrograde. We have S1 and S2. It's during the systole, and we have the D during diastole, and we have the A is during atrial contractions. Some places will call it AR, atrial like reversal. And depend on the pathology and the thing that the patient had, you will see the abnormality. For example, absence of A wave, absence of blunted S, reverse S in systolic reversal and MR. And we can have it also in diastole. We can measure the deceleration time of the D wave, the duration of the A wave. It is advanced. Sometimes it's difficult to get the sample volume at that place. However, we need at least the S and D, which is really like nicely presented here. How to optimize it? Just what I can say it in short, zoom it, try to open the vessel and go half centimeter to, they said, to 2 centimeters. Although some resources said do not go deep because the waveform will be changed. Okay? And zoom it. The most important is to have a good visualization for the volume. And the sample volume, it should be small. Where is it? Yeah, 2 to 3. should be smaller, not 4, 2 to 3. But if you take 4 and it's good samples, it will be fine. This is an article about spectral Doppler in the pulmonary veins. It's really nice with a lot of illustrations. What's the time?
15.
Okay, this is the last thing. So the hepatic vein, how many veins we have? We can see 3 veins. We can see the right, the left, and the middle. The most common one that we pulse is the middle because it's the most parallel for us. The waveform, forget about the one on the left. We have 2 antegrade and 2 retrograde. We have the S coming with systole of the RV and pulling of the tricuspid valve annulus, which will cause some suction effect, and it's the most prominent forward flow. Then the V at the end of systole. Then we will have the D with the tricuspid valve opening and blood flow to the RV, and then you have the A, which is the atrial contraction. And also, I kept those just for you if you want to read, because anyone who wants the slide, I will give it to him. It will change normally with respiration. So whenever we inhale, there will be negative pressure in the chest. There will be more forward flow, the D, the S and the D. And with expiration, there will be a less forward flow. And just they said the first B wave will be a bit prominent, which is part of the normal. And just by recording the hepatic, we can diagnose a lot of diseases. Like there were like very long list. For example, this one is constrictive pericarditis, restrictive cardiomyopathy, any restriction or like pulmonary hypertension, tricuspid stenosis, it will be reflected there. This one, any idea? I didn't know it before I read. They say when you have systolic dysfunction of the RB, the S wave will be really low, lower than the D. Before I read it, truly, I have never thought about it. So whatever you know, you will start to notice, which is really amazing. Yeah, I only took 4 out of 8, 9, 10 things. And how to optimize it? The sample volume, almost like the pulmonary veins, it should be small, and you should take the most aligned vessel that you have. It doesn't make a difference. And this is the article that I was like reviewing, and I took all the numbers from. Yeah, Bender. I remember Dr. was telling me about him. What did I left? I didn't mention. To pulse the LV, the RV, the descending aorta, the abdominal aorta, pulmonary arteries, any shunt, any abnormal flow, superior vena cava, left atrial appendage, and some they are pulsing even the coronaries. Whenever they see a coronaries, they pulse it. So pulse wave, it's a really important entity. I couldn't summarize everything in my mind in this lecture, but I hope that I just tell you that take care of the pulse wave. And I was going to say that for the juniors, whoever is beginning like cardiology or the guys from the ICU who want to learn transthoracic, this article is one of the most important things to start with. It will tell you the views, the pulses, the things that you need, the things that you don't need, and it's a good start. And Doppler, it's what's give the heart its true color, lovely look. And with that, I conclude.
That is nice.
And thank you, everyone.
Yeah,